Over to Kavita for her anterior segment trauma tips.
Thank you, Dr. Natarajan, for having me be part of your wonderful IC. So, I'll be talking about how to manage anterior segment trauma. I think corneal trauma is essentially the second major cause of blindness. And it's very important to know how to manage this because it's affecting mostly younger individuals, probably kids when they're playing, or it's usually an occupational hazard, like, somebody is working. So, not only does it cause obviously an emotional trauma because they at a young age they're undergoing this visual loss or potential visual loss, but also he's going to take that much time off from work. So the psychological and economic trauma, history taking is very important, especially if it's happening at work, that how it's happened, what was the object, what was the size of the object, because sometimes you may miss out a potential retained intraocular foreign body if it's like if he was using a hammer and chisel especially, and whether that like what force that when he's trying to chisel something, did something enter his eye, because then you have to look for a retained foreign body, or if it's just a small or like a large object which went and hit his eye, which is going to be more in terms of just a blunt trauma but or not in retained intraocular foreign body. And of course you have to see what he has been treated elsewhere, what medications, the antibiotic and the tetanus prophylaxis as needed. Visual acuity, pinhole, and the projection of light is very important, especially if you see something like this. Make sure at least you're looking at the pupillary, like the consensual pupillary reaction, figure out what's going on. And this is important, because if you see something like this, then make sure you're documenting all of this when you pay for taking up the patient for surgery. Also, Dr. Natarajan stresses a lot about taking a video consent, like consent and counseling, very very important, because when a patient comes with this injury, next day he's going to expect 6x6 vision, and so you may need to make sure, and then he's going to say, oh, you did my surgery and I can't see. So he's never going to know unless you counsel him and make it very very clear that this, if you're not seeing, it is because of his injury, because of the impact of the injury. Because in the patient's mind, he's always going to associate the post-op result with your surgery and not with the injury. So you have to make clear that you de-associate the two things, the surgery and the injury, and put all the blame on the injury. So just save yourself and just no, that's joking, but make sure that you counsel the patient properly, and examine the patient on slit lamp, look at the extent and depth of the laceration, also look at the uveal tissue for viability, see if the lens is affected, vitreous. And Seidel tear, sometimes you'll feel like it's a lamella, especially these so-called self-sealing tears, where patients have been told that yes, you don't need surgery, and they come back with end off to us, because the patient is not going to just go around without touching his eye. He's going to rub the eye, squeeze the eye, and he's that's going to open, even if it's opening like temporarily. Look for the Seidels test. If the Seidels is positive, even if it's so-called self-sealing, please go ahead and suture. Karubi ma'am has talked about at length about this, so I'm going to skip this. Management of the corneal tear, if it is very small, like even sir was mentioning, are there any cases where you don't need to do anything? Yes, if it's very small, Seidels is negative, very like less than 2 millimeters, you could use a glue, but I would avoid using a glue if it's in the visual axis, because that glue is going to cause a lot of haze, scarring, and vascularization. But if it's a peripheral, small 2 millimeters, then you can use glue, and these patients do very well. Okay, especially if it's a younger, a child, or who's, you're worried that if it's like sutures, again you have to go back and take out the sutures because the glue is just going to fall off on its own. So like I said, you can use glues if it's smaller peripheral. Now, when you're suturing a corneal tear, it is really not like just suturing any other part of the body, not like suturing the eyelid, unfortunately. I mean, I wish it was that simple. Here, what is happening, it's the first lens of your eye. It is the first refractive surface of the eye. So, at one point, you want to get structural integrity, but at the second point, you want to like also maintain corneal asphericity, which is the cornea is steeper in the center and becomes flatter towards the periphery, because the minute you lose that, you're going to get heavy astigmatism. You may feel you've done a wonderful job, the child you've sutured him, he lands up with -9, -10 astigmatism. It's useless to that child. So make sure you're keeping all these principles in mind. Now, whenever there is a tear, there is an effect of the laceration on the cornea in terms of astigmatism and altering the topography. There's an effect because you're suturing the cornea, and of course normal wound healing. Now, what happens when there's a tear? Basically, it's flattening. You see the center is completely flattened out, and also if you suture, it's going to flatten in that periphery, but it's going to get steeper away from your suture. So how do you decide the length of the sutures? What you need to do is make sure that the sutures are completely placed in such a way that each suture, the zone of compression, is overlapping the other zone. So that length has to be long enough. Now here, if you see, and let's go to the next picture, you can see, like, if you're taking shorter sutures far away from each other, here there is no zone of the zone of compression is not overlapping, so it's going to leak in that zone. So the thumb rule is that the length should be, it should be longer sutures. Now how should this and how deep should they be? If it is ideally it should be at 90% depth, and most of the times we are able to maintain this depth. And make sure that you're like holding the needle a little away from the tip, because if you go closer to the tip, you're going to go more superficial. So hold it away from the tip and pass the entire thing, and that's how you will do well. Now, entry and exit bite, it's a myth that if the tear is perpendicular, then your entry and exit will be the same distance from your surface where you're seeing. But if your tear is oblique, then don't, if you try and make the entry and the exit point at the same area, then it's going to cause overriding. So be mindful of this also. This is how it will look at the end. You know, the entire arc should be at one, symmetrical. So what you should need to do is imagine a perpendicular line and pass your sutures. Now this is very poor suturing. This has been obviously seen by us, done elsewhere. Why I'm saying it's poor suturing? Because it's a lot of malapposition, and look at that exposed knots. That's a complete no. Please do not leave the knots like this. 10-0 sutures can easily be buried. This patient was very symptomatic, and we went ahead and did a resuturing for her. So now lineal tear, corneal tear, this is please remember this. If your your tear is through and through, the central sutures will be shorter and peripheral are going to be longer, and long and tight in the periphery and short in the center, because like I said, the sutures are going to cause flattening. So keep it shorter in the center. If you have angular tears, now if you see this tear, it is an angular tear, and the angle is actually here, it is away from the visual axis. So what I'm doing is I'm going right through the angle and passing through suture. But had that tip of that angle been in the visual axis, I would have done it and passed it through the other arms of that angle. Now, if you stellate something like this, these are the most difficult, it's very like, in fact, the OR staff also gets impatient because it's very difficult to close these sutures. Sometimes in the end, you may just have to put a little bit of tissue adhesive or put a BCL at the end. And this purse string suture has been described in literature for whoever wants to try. I think this also is a great technique. Now, another tip here is that if you see that there is iris in the wound, the tendency is to go through the corneal tear and keep pushing the iris in. That's the worst thing to do, because at that point the cornea is so friable. You're going to cause some corneal loss. So some tissue is just going to snip away. So what you should do is as simple as that. Just go in through the side port, inject viscoelastic. In 90% of the cases, the iris will just fall back and your life becomes so much more easier. So don't try and ever push the iris in through the corneal tear. That's a complete no-no. Now, what iris do we retain and what we don't? If it's prolapsed for more than 24 hours, ideally it should be cut. Sometimes you could retain, use your own judgment. This, of course, has to be retained. It looks healthy. Even if it's not a very fresh tear, you can retain. Something like this, no, a complete no. Something like this, of course, is a complete no. You're going to go ahead and excise all of this. So there's no two ways about that. Now, this is very interesting because it doesn't really look like a corneal tear, but this was a corneal tear. This patient came with this extensive tissue loss. Even on the right-hand side, it was very surprising that this is how the patient came. In fact, I was so shocked to see the injury was probably 15 days old, and the patient was in the village somewhere. So you have to go ahead and do some kind of a corneal transplant. Like I did a patch graft and I did a corneal transplant in the other patient. If there's vitreous incarceration, of course you have to do a vitrectomy. Sometimes you may have to take your help of the retina colleague because the extent is not seen. You have to keep suturing as much as possible. Now, what happens when there's a corneal trauma with cataract? Ideally, you're supposed to wait for 3 months, get all the sutures out, and then plan the cataract surgery. There are some cases where you will do a primary cataract surgery. If it's a child, in an adult, if the capsule is ruptured, logistical issues sometimes, like I'll show one case, or if you're combining a case. Now this, you can see the picture. This is how the patient came. Nice corneal tear, not very large, but the patient was a child. and with a nice ruptured lens capsule. So we did sutured the tear, and we also put in the lens at the same point. This is another patient of mine, the graft rupture, but because logistically she did not want to come back and she was from the village, we did both at the same time. We used the IOL measurements from the other eye. Just have a few more pictures here. You can see this is where I've done a primary tear suturing, then secondary, and this is where you're doing it sequentially. This case is again, you're just simple, you're just aspirating the cataract, inserting the IOL, and the other case below is where you're doing a vitrectomy. I'm just showing the case below because the sutures are not out, but since the patient had a vitreous hemorrhage, patient came from elsewhere, we still had to go ahead with the surgery. And this is another case, traumatic cataract with mydriasis, where you can go ahead and do a fourth row pupilloplasty after addressing the primary cataract. So this is how the result is. So in conclusion, you suture maintaining the keratorefractive principles. Make sure you maintain corneal asphericity and decrease astigmatism to improve the outcomes. Thank you.
Thank you, Kavita. Just one question for you. If you have a cornea which is not faring too well after your traumatic cataract, after how many days you would do the keratoplasty? And yeah, that's the question.
So if you mean in terms of corneal edema or just the corneal
Opacification.
So I think I would at least wait for, if it's a child, obviously because you're worried about amblyopia, I would move faster, maybe 3 months. But if it's an adult, I soon see no harm in waiting for 6 months, giving that cornea time to revive, and then plan the keratoplasty, endothelial or full thickness as needed.
And what about IOL? If you have to put it, if you've just done a plain simple cataract extraction at the first go, after how many days you would put in a IOL?
You mean if you've done a corneal tear in the first, you've just done a lens aspiration?
Lens aspiration, corneal.
So again,
tear,
like that first, the case which I showed, in fact, it was a child. It was I think, a 6 years old child. So we just used the IOL measurements of the other eye. I talked to the pediatric ophthalmologist, and we decided, because it was a peripheral tear, I didn't think it will cause so much of an effect on the biometry. So we put in a primary IOL. But had it been an adult where we're just the capsule is ruptured, I would have sutured the corneal tear and maybe done it like at around, ideally they say at 3 months. But I know in practical situations, sometimes I would say it's best to wait for at least 4 to 6 weeks.
Thank you so much,
Thank you,
Kavita.
Thank
That
you.
was a very nice.